short of time, so we'll call on the first presenter, and is Professor Dr. Sonali V. Kumar. And the time for presentation is 4 minutes.
A very good evening to all of you. The title of the study which I am going to present today is Hidden Orbital Inert Foreign Body, a tale of two cases. It's not moving. It's not moving. So orbital foreign bodies are encountered whenever there is orbital and facial trauma. Organic foreign bodies are removed along with some metallic foreign bodies, as it can cause severe inflammation and infection. However, inert foreign bodies are left behind when it is located near to optic nerve or orbital apex. In cases where foreign bodies are not removed because of its inert nature, this patient should be followed up regularly to look for its remote effects. So herein we report two unusual cases of hidden orbital foreign body, which was initially presumed to be inert, but later presented with vague symptoms and which misled the diagnosis for a few days. So our first patient presented with an injury to his right eye 20 years back, followed by he developed sudden diminished vision in the same eye. He was diagnosed as a case of open globe injury, and CT orbit was done, which showed intraorbital foreign body which was deep seated. So he underwent wound exploration and primary repair. However, the inner foreign body was not removed at that time because it was thought to be of inert nature. Patient was then lost to follow-up, and then he again presented in 2019 with an episode of upper eyelid swelling. He underwent IND and he underwent biopsy also, and which suggested inflammatory etiology. However, his condition did not improve and he sought consultation at our center. So ocular examination showed no perception of light in the right eye, and left eye it was 6/6. Clinical examination showed right eye upper eyelid swelling with a mechanical ptosis, and slit lamp examination showed triangular vascular mass which was encroaching upon cornea, and other details could not be visualized because of the corneal opacity. The left eye examination was essentially normal, and CT orbit was done, which showed hyperdense extracorneal lesion which was located in the supromedial expert and which was abetting the superior rectus and the medial rectus. So he underwent anti-orbitotomy, and 10 mm size stony foreign body was removed from the affected side. He recovered completely within 2 weeks, and he did not show any sign of recurrence at 6 months follow-up. So our second patient presented with a complaints of watering from left eye, and he had given a history of injury to the same eye with a splinter 2 years back, but no intervention was done in that time, and no visible wound was found. But 1 year following injury, he started experiencing watering from the same eye. So anti-segment and fundus evaluation in the both eye were essentially normal. Lacrimal irrigation test was done, which showed patent passage in the right eye, and in the left eye it was heart stop was found, and there was a regurgitation through opposite puncta. So he was diagnosed as a case of chronic dacrocystitis left eye. CT orbit was done as he had given a history of injury, and we showed hyperdense lesion extracorneal in the infromedial part which was abetting the optic glove. So he underwent external dacrocystorhinostomy, and during fashioning of the lacrimal and the nasal mucosal flap, the foreign body was noticed in the infromedial part, and it was removed in total, and it appeared to be part of the steel. So as per traditional teaching, inert foreign bodies are not touched, as chances of infection are very rare. However, patient harboring these inert foreign bodies sometimes can present with vague symptoms and confusing clinical picture. So in our first case, the foreign body was not removed at initial presentation, as it was thought to be of inert nature, but the importance of regular checkup was not emphasized. So over these years, the foreign body migrated entirely and got lodged in the supromedial part, and which resulted in the recurrent episode of upper eyelid swelling. So second case presented with a watering after 1 year following injury, and he was advised external DSI, it was attributed initially to nasolacrimal duct obstruction. However, during surgery, the foreign body was found in the infromedial part, which was obstructing the NLD. So this case demonstrated that there is a possibility that foreign body can get lodged within the orbit in the absence of external wound. And we speculate that the foreign body must have traveled with high velocity through the lower fornix at the time of injury. So Carroll et al. Also reported patient became symptomatic 27 years after injury, and Nair et al. Also reported in the communication that patient became symptomatic 13 years after injury. So to conclude, inert foreign body can pose a serious diagnostic channel. It can also have grave consequences like organic and metallic foreign body. And through these case reports, we want to raise awareness about the potential complications which are associated with foreign body and which is very crucial for the proper care of the patient. So these are my references. Thank you.
Thank you. So next speaker is Dr. Shrutakirti Parida. And the topic is clinico-demographic profile and visual outcome in pediatric traumatic cataract, a prospective study. Timer to start only when speaker starts his presentation. Huh?
A very good evening to one and all. My study is titled Clinico-Demographic Profile and Visual Outcomes of Pediatric Traumatic Cataract, a prospective interventional study. I have no financial interest to disclose. The objectives of this presentation are to study the clinico-demographic profile of pediatric traumatic cataract in a tertiary care hospital and to find out the predictors of final visual outcomes in these patients. This was a prospective interventional study which was done from February 2022 to February 2024 in children aged 3 to 15 years who were diagnosed with traumatic cataract. All the relevant data were collected at presentation and subsequent follow-ups with a minimum of 1 year of follow-up. We did the cataract extraction with either pediatric lens aspiration using the bimanual technique or the pars plana lensectomy using the vitrector as per the case needed. And PPC plus AV was done in children who were less than 8 years with an intact posterior capsule. Postoperatively, glasses or contact lens followed by amblyopia therapy was given to the patients, and other medical and surgical management was done for other ocular morbidities wherever needed. The statistical analysis was done, and a p-value of less than 0.05 was considered to be significant. Coming to the results, the mean age at presentation was 9.37 plus minus 5.44 years, with a higher preponderance of the boys. There was secondary glaucoma reported in 6 out of the 41 eyes which were managed medically. The mean time interval elapsed between injury and cataract surgery was 4.38 plus minus 0.004 months. 9 out of the 41 eyes developed sensory strabismus, of which exotropia was most common. The mean best-corrected visual acuity at presentation was 1.5 plus minus 0.14 logMAR units, which has improved at final follow-up to 0.66 plus minus 0.03 logMAR units, which was quite good. Coming to the mode of injury, in 53.6% patients, the mode of injury was penetrating trauma, followed by blunt trauma in 38.5%. The most common objects which caused injury were stick, followed by iron rod, seizures, and broken glasses. This is the list of the associated ocular injuries in the anterior and posterior segment, which we can see. Coming to the cataract morphology, fluffy white cortical cataract followed by calcified white cataract was the most common cataract morphology. In the type of the surgical intervention, pediatric lens aspiration plus PPC, AV, and PCIOL implantation was done in 22 out of the 41 eyes, followed by corneal tear repair with pediatric lens aspiration in the first setting, followed by secondary oil implantation in the second setting after 3 to 4 months in 8 eyes, and the rest of the procedures are like this. So coming to discussion, pediatric traumatic cataract is one of the major causes of unilateral cataract. Several complications are reported after cataract surgery in the children, including PCO formation, fibrinous uveitis, IOL decentration, post-cyanic A, and potential for developing amblyopia. There are various factors which affect the visual outcome in the pediatric patients, including age at presentation, type of the injury, associated ocular injuries, time elapsed between injury and treatment, and the various treatment modalities with treatment adherence also. Majority of the children in our study were of the school-going age group. The boys were affected more than the girls because of involvement in more aggressive and violent nature of the activities, which was also at par with studies done by Goget et al., Shah et al., and Reddy et al. In our study, 56% patients showed improvement of vision at final follow-up post-operatively. In our study, children with penetrating trauma, posterior segment involved multiple surgeries due to coexisting ocular morbidities, rest intraocular pressure, poor vision at presentation, and the increased interval between injury and surgery had a poor outcome. And most of these injuries could have been prevented by adopting safety measures by children and their parents. So to conclude, penetrating trauma, posterior segment involvement, multiple surgeries, raised intraocular pressure, increased interval between injury and surgical management were the predictors of poor visual prognosis in our patients. There is a need for proper counseling of the parents and the caregivers about the importance of adoption of safety measures both at school and home. The Take Clinic message is an ounce of prevention is always better than cure, so there is a need for the parents and caregivers to adopt the safety measures to prevent ocular trauma in the pediatric population. Thank you. These are my references.
Thank you. The next presentation is by Dr. Kishore Kumar, and the topic is ophthalmic implications following orbital trauma.
Good evening, everyone. I will be presenting on study on ophthalmic implications following orbital trauma. Coming to the introduction, road traffic accidents are the major public health problems causing high rates of morbidity and mortality. RTA is ranked 8th most common cause of death worldwide. RTA are responsible for a significant number of ocular injuries. Consequences following RTA may vary from a minor trauma to significant vision-threatening complications. CT scan of face, orbit, and skull with three-dimensional reconstructed imaging is quite helpful in diagnosis and decision-making. It has been reported that about 90% of ocular trauma are preventable with the appropriate use of protective safety glasses, helmet, and seat belts. The current study is a prospective cross-sectional study which was conducted at a tertiary care center to evaluate the epidemiology, clinico-radiological pattern of injury following orbital trauma. Total of 100 patients attending the casualty following the history of orbital trauma were included in the study. The study duration is of 6 months. Coming to the results, the most common age distribution is between 21 to 30 years. That is, out of 100 patients, 38 patients were in between 21 to 30 years, and most of them were males. That is 86 cases, while 14 were female. The most common mode of injury is due to had a history of road traffic accident. That is 68%, while 32% patients had other non-RTA causes due to assault, cell-fall, sports injury, and agriculture-related trauma. And the most common injury subtype is lid laceration, followed by ecchymosis, subconjunctival hemorrhage, lid abrasion, and corneal perforation. Coming to the CT imaging reports, out of 100 patients, the 40 patients had orbital fracture. In that, the 24 patients had one wall fracture, 14 patients had two wall, and the rest another 2 patients had 3 wall fracture. And most common orbital wall injured was lateral wall, followed by medial wall, inferior wall, and superior wall. Discussion. Ocular trauma is the one of the major cause of avoidable blindness. In this study, male is to female ratio was 6:1. That is, higher incidence of ocular trauma is noted in the males than the females. The study done by Maure et al. From Uttar Pradesh reported 88.40% males and 11.60 females were injury victims. Kumar Jay et al. From India reported incidence as 77.6% in males and 22.4% in females. This higher incidence of ocular trauma in an RTA in men can be explained by their more outdoor activities with increased traveling and rash driving. 56% patients treated with conservative medical management, while 44% patients required active intervention. The study done by Maura et al. Reported that commonest ocular injury was ecchymosis, followed by eyelid laceration, subconjunctival hemorrhage, and globe injury. Kumar J et al. Reported periorbital edema with ecchymosis, followed by eyelid laceration as a commonest type of injury. The commonest ocular injury reported by Mudaliar et al. Was subconjunctival hemorrhage, followed by ecchymosis. Orbit and periocular structures are the first structure to take impact of the injury in an accident. Coming to the conclusion, in conclusion, consequences of RTA may vary from simple abrasion to extremes of complete blindness in the affected eye. Males are predominantly affected than females. Multiple orbital fractures, intraocular hemorrhage, and posterior segment trauma, poor initial visual acuity are the sum of the manifestations of ocular trauma. Public health education regarding use of helmet and seat belt, early reporting, and appropriate intervention may reduce the vision-threatening complication and blindness in RTA-related ocular trauma. As road traffic accident causes lot of morbidity and mortality, safety measures has to be undertaken properly. The need of the hour is to abide by the traffic rules strictly, as prevention is always better than cure. These are my reference, and thank you.
Thank you. And the next speaker is Dr. Tanvi Gaunkar, rehabilitating the traumatized eye.
A very good evening to everyone. My name is Dr. Tanvi, and I will be taking you through the journey of rehabilitating a traumatized eye. So a young adolescent girl presented to us with complaints of diminution of vision, pain and photophobia for 2 months. She had a history of firecracker injury 2 months ago, and she had undergone lens aspiration and pars plana vitrectomy elsewhere 6 weeks ago. So on examination, her vision was finger counting close to face PR accurate. The IOP was 50 millimeters of mercury. She was aphakic, and the fundus was hazily seen, and it showed a cup-disc ratio of 0.6 with thinning of the inferior neuroretinal rim. So we decided to start her on maximum anti-glaucoma medications with sodium chloride drops. At the end of 1 week, her IOP still hovered at around 34 millimeters of mercury. So we decided to go ahead and do a surgical intervention in the form of an Ahmed glaucoma valve with a single loop fixation of PCIOL. So in the first picture, as we can see, the AGV plate was placed in the supratemporal quadrant. It was fixed to the sclera using nylon suture 80. The tube was trimmed and placed into the anterior chamber through a 23 gauge opening. Next, a superior clear corneal incision was made, and the IOL was placed into the inferior rim, and the superior portion of it was fixed to the upper scleral wound. So on post-operative day 1, the patient regained a vision of about 624 BCVA. The IOP was 12 millimeters of mercury, and the cornea was clear. And this is the AGV tube, which was well seen in the anterior chamber. Further examination showed a cup-disc ratio of 0.6 with thinning of the inferior neuroretinal rim, and the OCT macula showed a central macular thickness of 180, confirming why the patient's BCVA was 6/24. Unfortunately, the patient now sustained a second trauma 6 days later, and she presented with a BCVA back to finger counting 1 meter, PR accurate, and an IOP of 38 millimeters of mercury. On examination, we can see that the AGV tube was not present in the anterior chamber. So now we know this patient had tube retraction. So we decided to go ahead and surgically intervene. A surgical exploration was done, and we noticed that the sutures that were used to fix the AGV plate to the sclera were now broken. So the plate was refixed to the sclera using 80 nylon sutures, 2 mm anterior to its original location, and the tube was now reinserted into the anterior chamber through the same opening. So this was the outcome at the end of 1 week. At the end of 5 months, the patient continued to maintain an IOP of 12 millimeters of mercury, and at the end of 6 months, unfortunately, the patient now developed a tenon cyst. So the tenon cyst was medically managed for the next 3 months. The patient was started on anti-glaucoma medications, and the IOP hovered at around 14 to 16 millimeters of mercury. The AGMs were sequentially withdrawn over the next 4 weeks, and at 12 months, the IOP was now 12 millimeters of mercury. So a retrospective study which was done by Sajdev et al. Reported the most common complication of combined scleral fixated intraocular lens with Ahmed glaucoma valve to be bullous keratopathy and choroidal detachment. However, in our patient, the most common complication that we saw was tube retraction and plate migration and encapsulation. So I'd like to conclude that the combined approach of single loop fixation of PCIOL with Ahmed glaucoma valve implantation is an effective procedure for the rehabilitation of patients with post-traumatic glaucoma with 180-degree inferior capsular remnants and extensive conjunctival scarring. Thank you.
So next speaker is Dr. Amruta Shri A, and will be speaking on a challenging case of ocular trauma by an umbrella in a child.
I'll be presenting a challenging case of ocular trauma by an umbrella in a child. Apart from workplace injuries, most commonly children are the ones who encounter ocular trauma while playing. The management and prognosis depend on the type, composition, and location of the foreign body. Large foreign bodies do have the risk of intracranial penetration as well as high risk of secondary infection. Transorbital foreign bodies can even penetrate intracranial, in which case we need to take a help of a neurosurgeon. Though it's rare, there are reported ocular injuries with various parts of an umbrella like its rib stretcher, metal hinge, and wire leading to penetrating injury. While the handle and the shaft can cause blunt trauma due to the force applied from the handle of a release spring mechanism on an umbrella. Here is a case of an 8-year-old boy presented with accidental injury to left eye while playing with an umbrella, came with complaints of pain and foreign body in the left eye. Patient was brought to casualty with the metal hinge of the umbrella stuck to the left eye. An anterior segment showed the metal hinge of the umbrella, which was noted subconjunctivally in the nasal aspect of the eye. Globe, however, appeared intact and IOP was digitally normal. This was a metal hinge which was stuck to the left eye, and great care was taken by the attenders while shifting the patient to keep the foreign body undisturbed. A provisional diagnosis was made as penetrating subconjunctival foreign body with query occult scleral tear, and the patient was taken up for globe exploration under general anesthesia. It was noted that the foreign body had penetrated nasally with superior extension to the frontal bone, and there was no evidence of any occult scleral tear. It was carefully dissected from the subconjunctival space and externalized. After ruling out scleral tear, the residual conjunctiva was sutured. This is the post-operative anterior segment. On X-ray, there was no evidence of foreign body-related orbital fracture, and posterior segment was normal. Accidental ocular trauma are common in children. Eye injuries due to the umbrella are about 18%. Umbrella can be a source of grievous ocular injury ranging from blunt trauma, penetrating trauma, and orbital fractures. While the handle and the shaft can cause blunt trauma due to the force applied by the handle of a release spring mechanism, umbrella-related injury can be very severe with intracranial damage, as reported by Noda et al. In 2010 about a case of perforating eyelid injury caused by the metal tip of an umbrella leading to edema of the brain due to the penetration of the umbrella tip. In 2016, Raman et al. Reported a case of transorbital penetrating intracranial injury with an umbrella wire. The patient had removed the umbrella wire by himself, which had traversed the SOF, leading to cavernous internal carotid artery injury and thrombosis. We were lucky that our patient was brought with the hinge of the umbrella stuck to the eye in situ, which helped us in removing the foreign body with minimal ocular damage. In another case reported by Norton et al., a child had an upper lid laceration involving the superior canaliculus, but due to disproportionate swelling of the upper lid when the CT was done, a cribriform plate fracture with a fracture leak extending to the roof and anterior cranial fossa was noted, but there was no evidence of any CSF leak. In our case, we were fortunate since there was no intraocular penetration, neither intracranial extension of the injury, and the metal hinge was confined to the subconjunctival space. In conclusion, children should be monitored and they should not be left unattended while playing. The key is to be aware of what types of objects and situations have potential cause injury, to exercise caution. The quick arrival of the patient after the injury without any delay and the prompt action in cutting the umbrella played an important role in outcomes of surgery. Removing large foreign bodies by attenders or bystanders can cause more damage to the eye and other structures. Thus, it's always better to dismantle the distal part of the foreign body and to plan surgical intervention after knowing the extent of the wound on the staple in the OT itself. One should keep in mind the possibility of orbital tissue damage, orbital wall fracture, associated intracranial injury in these types of large orbital foreign bodies, and look for associated symptoms clinically. These are my references. Thank you.
Thank you. Next is by Dr. Apurva N. A study of workplace injury in eye to eye in a tertiary eye care center.
Good evening, everyone. My topic is on a study of workplace injury to eye in a tertiary eye care center. There is no financial disclosure. Introduction, the work-related injuries or injuries and illnesses resulting from events or exposures occurring in the workplace. The occupational eye injury, it is one of the important cause for preventable vision loss worldwide. The work-related eye injuries hurt workers and their families while imposing a huge burden with respect to manpower and social costs. The objective of the study, it is to study the demographics, mode and type of ophthalmic workplace injury and its management. Coming to the methodology, this is a retrospective study of patients with workplace injury to eye in coming to the tertiary eye care center from January 2022 to August 2023. The source of the study was the outpatient ward and operative records at a tertiary care center. We have included 225 patients, which was a retrospective study. The objective data recorded include the basic demographic information, the mode of injury, the time of injury, then the cause for immediate visual loss and the management. Coming to the results, here 94% were contributed to the males, and when coming to the age distribution, the 41%, that is the highest, coming under the age group of 20 to 30 years. Coming to the mode of injury, the most common in our study, the mode of injury was due to by the wooden stick injury, followed by the iron nail injury. Coming to the visual acuity, when they come to the hospital at the presentation, the two cases were presented with there is no perception of light, and most of the patient had vision, like around 94 cases had more than 6/12 vision. Coming to the immediate cause of visual loss, which have come to the center, it was like 61 cases, around 27%. It was due to the corneal tear, followed by vitreous hemorrhage and traumatic cataract, followed by. Coming to the majority of workplace injuries in our study, it happened during the late afternoon in around 184 cases, around 81%. The most of them are self-inflicted in around 97% of cases. And around 53% were managed with the medical line of treatment. The most common indication among the study population for surgical intervention, it was a corneal tear. And 89% workers did not use the eye protective devices. And coming to the discussion, the majority of workers in our study were adult males belonging to the age group of 20 to 30 years of age. In our study, the wooden stick injuries was the common mode, followed by the iron nail injuries and chemical injuries. And the majority of the workplace injuries happened during the late afternoon. The most of them were self-inflicted, and 89% workers did not use the eye protective devices. And coming to the Chinyalu et al. Reported majority were males with the mean age of 32 years. The most common mode of injury in their study was blunt trauma, and 98% workers did not use eye protective devices, and most injuries occurred in the late afternoon. Then another study by Arunova Kundu et al. Reported the majority are males with age group of 31 to 40 years. The most common injury in this is corneal foreign body, and 88.3% were not using protective devices. The another study by Terence et al. Reported that 88% were males with mean age 31.5 years. The most common injury in this study is corneal foreign body, and only 2.5% reported to having eye protective devices at the time of injury. Coming to the conclusion, the workplace protective gears have to be provided with the regular information, education, and compulsory laws to use them have to be enforced. The most important thing the patients can do to protect vision at work is to always wear appropriate protective eyewear. This can prevent more than 90% of the serious eye injuries. The workers should know the dangers in their working environment, and that is possible by continuous information education at periodic intervals by employing companies or institutions. The employers and employees should recognize the importance of workplace eye safety. Ocular injuries can be reduced by the implementation of appropriate preventive strategies to address each risk factor. These are my references. Thank you.
Thank you. And next I would like to invite Dr. Vatke Vidya Arun Kumar.
Good evening, everyone. No financial disclosures. I will be presenting a brief report of 5 eyes with blunt ocular trauma, secondary to recoil from bungee cord used in motorbikes. So ocular trauma is a common cause of visual disability. Most ocular injuries occur in young males in the occupational setting, as we saw in the earlier paper, but trauma during domestic activities account for 18.3% of eye injuries. Bungee cords produce a great amount of potential energy when stressed and are therefore capable of transmitting sufficient force to cause severe blunt ocular trauma. This image shows a bungee cord which has the potential to cause both blunt and penetrating injuries. In addition, the end of these cords contain sharp hooks. So aim of the study was to discuss the mechanism of injury and characterize the clinical features of ocular trauma associated with bungee cord injuries in consecutive series of patients seen at a single outpatient department at a tertiary eye care at Kolkata. It was a retrospective study, studied over a period of 6 months, and 5 patients were found with bungee cord injuries in this duration. The patient demographics, BCVA, slit lamp biomicroscopic findings, disc and fundus findings, gonioscopy records, extent of ocular injuries, history of use of ocular protection, interventions required, and final visual outcomes were recorded. The most frequently observed anterior segment pathologies were traumatic iritis and angle recession. Most common posterior segment findings were peripheral commotio retinae. 3 of the 5 patients were treated conservatively. 1 patient was advised surgical intervention for anterior subluxation of crystalline lens, and 1 patient had undergone corneal tear repair elsewhere and required corneal wound resuturing. Follow-up intervals ranged from 0 to 10 months. Visual acuity at final examination ranged from 20/13 to 20/400 with a median of 20/40. These are the injuries summarized. So anterior segment injuries, patient 1 had iritis and subluxated lens, also with commotion retina in the posterior segment. Patient 2 had angle recession, iris sphincter tears and iritis along with commotion retinae. Patient 3 had a corneoscleral laceration which underwent repair elsewhere and was needed resuturing because of a wound leak and exposed sutures. Patient 4 had angle recession, iris sphincter tear, iritis and traumatic cataract along with choroidal detachment. And patient 5 had commotion retina as well. So these are the anterior segment photographs. First patient showing the presence of circumcorneal congestion, traumatic iritis and presence of subluxated lens. And the second one is the resutured corneal wound. These are the posterior segment findings in our patients. First showing the fundus photograph with commotio retinae surrounding the optic nerve and temporal to the macula. The second picture showing OCT macula showing outer retinal layers defect in subfoveal region, and the third showing UBM with supraciliary effusion. So most injuries from bungee cords occur when the metal or plastic hook slips from its points of attachment while the cord is stretched. The mechanism of injury appears to be a combined blunt and high velocity missile injury with a possible sharp component from the hooks. Traffic rules, including bike modification guidelines, should include restriction on attachment of bungee cords on two-wheelers, and emphasis should be given on eye protection devices at workplace. Thank you.
Thank you. And the final presentation is by Dr.
Most common mode of stick injury was with the wooden stick, which accounted for about 31.25%. In that clinical examination, most commonly it was associated with a full thickness corneal tear, and the patients underwent wound exploration with corneal tear repair with cataract extraction. Other findings included partial thickness corneal repair and a scleral tear. We did a microbiological analysis in which most common organism we found was alpha hemolytic streptococci. We didn't find any growth in 6 cases. We found bacillus species in 3 and enterobacter aerogenes in 1 case. Majority of the patient underwent intravitreal antibiotics, vancomycin and ceftazidime with the core vitrectomy, 88 majority of the patients. And final visual acuity was more than 660 for more than 50% of the cases. 18.75% cases went into phthisis. So coming to the discussion, the mean age of our study was 7.65 years. Time of presentation about a day. Males are more commonly affected. Mode of injury was a stick. Most common finding was a full thickness corneal tear. Most common organism we isolated was alpha hemolytic streptococcus, and we had a final visual outcome of more than 6/16, 50%. If we compare with the other studies, our sample was having 16 cases as compared to others in a 1 year period. The mean age of presentation was 7.65 years. Most common gender affected was male, as in seen in other studies. Most common mode of injury in our study was a wooden stick injury. In some other studies, broomstick and scissor injury was also seen. The time reported in most of the patient, time of presentation was within 1 day. So mostly that attributed to the good visual outcome. Microbiological profile varied in almost all studies. Most commonly streptococcus was isolated. We isolated alpha hemolytic streptococcus, and majority of our patients underwent vitrectomy, leading to a visual outcome of more than 6/16, 50% of the cases. So to conclude, a successful anatomical and visual outcome can be attained in children with post-traumatic endophthalmitis with early presentation, prompt and aggressive treatment. Thank you.
Thank you so much.